Hello, and welcome to this podcast on clinical pharmacology and therapeutics. In this brief talk, we're going to look at acute coronary syndrome and angina, and use these examples as a way of talking about some of the most important classes of drugs commonly used in cardiology. So let's start with acute coronary syndrome. Acute coronary syndrome is a medical emergency, and in these therapeutics podcasts, I'm going to talk about all medical emergencies in roughly the same way. First, it is useful to have a definition and the basic signs and symptoms, then to have a way to break down the therapeutics. For the case of any medical or indeed surgical emergency, I tend to use the A, B, C, D classification. A is of course for airway, B is for breathing, C is for circulation, and D is for drugs. Note this is different to the traditional classification where D stands for disability. You should go through this basic scheme every time you are confronted with an emergency. Some examiners may get a little exasperated by hearing this again and again, but it ultimately shows that you do have a sensible method and are therefore safe. So let's apply these principles to acute coronary syndrome, starting with the definition. Acute coronary syndrome is a medical emergency characterized by the sudden onset of central crushing chest pain that may radiate down the arms or neck. Important signs include diaphoresis and other signs of adrenergic activation, together with characteristic ECG and enzyme changes. Importantly, acute coronary syndrome is a catch-all for unstable angina, ST and non-ST elevation myocardial infarction. Initial treatment should therefore be the same for all of these situations. So here is a 12-lead ECG that shows a fairly typical inferior myocardial infarction with ST elevation in 2, 3 and AVF. Also note the ST depression in leads 1, AVL and V2, together with some T-wave inversion. Treatment, as usual, involves A, B, C and D. For A, it is important to provide a secure airway, and although actual measures are not often needed for ACS, it might be necessary for patients who are unresponsive. For breathing, it is appropriate to give high-flow oxygen, most probably through a non-rebreather mask at 15 litres per minute. For circulation, it is important to get IV access and to take blood for things such as lipids, glucose, and cardiac enzymes. Note that these may need to be repeated at various intervals. For drugs, the big three for acute coronary syndrome are aspirin 300 mg, clopidogrel 300 mg, and heparin, usually enoxaparin, otherwise known as Clexane, given at a dose of 1 mg per kg subcutaneously. Other drugs that may be considered include a nitrate, such as GTN spray 2 puffs, morphine for analgesia, together with an antiemetic of course, and 5 mg atenolol, as this was shown in the ICIS-1 study to reduce arrhythmic death post-MI. Depending on the hospital policy and availability of resources, you may also need to consider the need for thrombolysis, which I'll be considering thrombolytics in more detail in a later podcast, but commonly used examples include streptokinase and tissue plasminogen activators, such as alteplase and tenecteplase. There are 4 important indications: characteristic history within 12 hours, ST elevation greater than 2 mm in 2 or more chest leads, that's V1 to V6, ST elevation greater than 1 mm in 2 or more limb leads, so that's 1, 2, 3, AVR, AVL and AVF, and a new onset left bundle branch block. You need 2 or more of these features to consider using thrombolysis. Lastly, under acute coronary syndrome, we're going to talk about the 4 drugs that patients should receive post-infarction. These drugs can be conveniently remembered as they all start with the letter A. They include aspirin, atorvastatin or another statin, atenolol, and an ACE inhibitor. All have been shown to reduce cardiovascular mortality and morbidity for patients after their heart attack. Finally, note that there is some evidence that clopidogrel should be given together with aspirin for 12 months after a non-ST elevation myocardial infarction, or if a stent has been placed during the patient's admission. I've included the dose of some important drugs here, as even though this is not usually examined, it is useful when starting out as a junior doctor to have some idea about the most common drugs that are used in their regimes. We shall be coming back to these lots in different podcasts, so hopefully they should slowly sink in. Right, so in summary, acute coronary syndrome is a medical emergency that encompasses unstable angina, ST elevation, and non-ST elevation myocardial infarction. It is well described by the characteristic history, together with expected ECG changes and blood rises in cardiac enzymes. Treatment should always include aspirin, clopidogrel, and enoxaparin, together with GTN and morphine pain relief. The type of definitive treatment will depend on local policy and availability of resources, but may include thrombolysis or angioplasty. Before discharge, all patients should be prescribed the 4 A's: aspirin, atorvastatin or other statin, atenolol, and an ACE inhibitor. We're now going to talk about the therapeutics of angina and use this as a way of introducing some core drugs that are used in cardiology and other specialties. So, first of all, what is angina? It is important to distinguish stable angina from unstable angina. Stable angina represents the presence of fixed atherosclerotic plaques in the coronary arteries that reduce blood supply to the myocardium and hence reduce oxygen supply. At rest, this may not be a problem as blood supply is adequate. However, when the patient exerts themselves, increasing the oxygen demand of the myocardium, supply of oxygen as delivered by the stenosed vessel is inadequate, and typical chest pain then results. Unstable angina, on the other hand, is a result of underlying plaque rupture and is characterized by new onset severe angina or suddenly worsening of previously stable angina. Unstable angina, as mentioned previously, is a form of acute coronary syndrome and is managed as previously discussed. We shall now discuss the treatment of stable angina. Now here is an algorithm that illustrates and summarizes the treatment. We shall be coming back to this later. Basically, the goals in treating angina are twofold. To firstly control symptoms that can be quite distressing, and secondly to prevent cardiovascular events. Different agents are deployed for each of these. However, before we begin to look at them, do not forget the importance of conservative treatments, such as smoking cessation, diet alteration, and exercise. There are 3 important drugs that are used to control the symptoms of angina. These are nitrates, beta blockers, and calcium channel blockers. These agents work by altering the demand-supply balance of the myocardium. Nitrates act as vasodilators, reducing preload. Beta blockers reduce the rate and force of cardiac contraction. And calcium channel blockers have actions both on the vasculature, resulting in vasodilatation, and on the heart, resulting in a decreased heart rate. The first-line agents, and those that will be most familiar to you, are nitrates. Nitrates are prodrugs that have their effect by acting as nitric oxide donors to vascular smooth muscle. Nitric oxide itself is important in increasing levels of cyclic GMP within the smooth muscle and eventually resulting in relaxation and thus vasodilatation. While both arteries and veins are affected by these agents, it is important to note that the veins are affected more. As mentioned earlier, this results in a reduction in venous return and preload, meaning that the heart has to perform less work and therefore has less demand for oxygen. This demand can hopefully be met by the stenosed vessels. Note also that nitrates decrease afterload and as such can have an important role in the treatment of cardiac failure. Nitrates can be either short-acting or long-acting. The short-acting preparation is called glyceryl trinitrate or GTN, while the long-acting agents are isosorbide mononitrate and dinitrate. The first-line agent used is GTN, which can be used for fast, effective relief of angina. Alternatively, it can be taken just before performing activities that are known to precipitate angina. GTN is administered as a sublingual tablet or as a spray, and its effects last around 30 minutes. These may be prolonged further with the use of transdermal and modified release preparations. Isozorboid mononitrate and dinitrate, on the other hand, are both available as oral tablets and have a longer duration of action. These are typically given to patients with frequent attacks of angina, typically greater than twice per week, that are inadequately controlled by GTN. Isozorboid mononitrate is more commonly used than dinitrate as it undergoes less first-pass metabolism. It is indicated also as a second-line therapy in patients who do not tolerate beta blockers. Note that GTN and isozorboid dinitrate are available as IV preparations and are used to relieve chest pain in acute myocardial infarction and to reduce preload in acute left ventricular failure. There are a few common side effects of nitrates. These include headaches, flushing, hypotension and dizziness from postural hypotension, and also tachycardia. With the use of the longer-acting nitrate preparations, such as transdermal GTN, isozorboid mononitrate, and dinitrate, tolerance can also develop, but this can be minimized by having drug-free periods of around 8 hours per day. Nitrates are obviously contraindicated in hypotension when the blood pressure is less than 90 systolic, or when there is valvular stenosis or hypertrophic obstructive cardiomyopathy. The most important drug interaction is with sildenafil, as this enhances the hypotensive effect of nitrate. The second class of drugs used in the symptomatic relief of angina are beta blockers. As mentioned earlier, they have a negatively chronotropic and ionotropic effect, as they act mainly on the beta-1 receptors of myocardium. This reduces oxygen demand on the myocardium, improving exercise tolerance and relieving symptoms. There are many different types of beta blockers which can be classified according to their actions. They can be either non-selective or selective beta-1 antagonists, non-selective partial agonists, and beta-1 and alpha-1 antagonists. An example of a non-selective beta blocker is propranolol, a drug that is commonly used to treat symptomatic anxiety and hypothyroidism. The selective beta blockers are metoprolol, bisoprolol, and atenolol. Importantly, the non-selective partial agonists such as oxprenolol and pindolol have an intrinsic sympathomimetic effect, as they are able to both block and stimulate adrenergic receptors. This has the advantage of causing less bradycardia and coldness of the extremities, particularly useful therefore in elderly patients. Combined beta-1 and alpha-1 blockers such as carvedilol and labetalol have an added arteriolar vasodilatational effect and thus lower peripheral vascular resistance. The accumulation and excretion of beta blockers are affected by their solubility. Some, such as propranolol and metoprolol, are more lipid soluble than others, meaning that they can easily cross the blood-brain barrier, causing centrally acting side effects such as sleep disturbance and nightmares. Water-soluble beta blockers such as atenolol are excreted primarily by the kidneys, and thus excretion of these drugs will be altered in renal failure. There are a number of side effects and contraindications to be aware of with the use of beta blockers. Ultimately, beta blockers are negatively ionotropic and can cause bradycardia. They are therefore contraindicated in patients with bradycardia and heart block. Beta blockers have multiple metabolic side effects, the most common examples of which are impaired glucose tolerance or diabetes and hyperlipidemia. For this reason, the combination of beta blockers and thiazide diuretics should be avoided. Non-selective forms in particular will block beta-2 as well as beta-1 receptors, inducing bronchospasm. Thus, beta blockers are contraindicated in patients with asthma. The unopposed action on alpha receptors in the vasculature causes vasoconstriction and cold extremities. This may be reduced with combined beta and alpha blockers, but nevertheless, beta blockers should not be given to patients with PVD. The main interaction to note with beta blockers is with the non-dihydropyridine calcium channel blockers, diltiazem and verapamil. These can further decrease the heart rate. However, note They are only contraindicated if they are being administered IV. The third and final drug used for the symptomatic management of angina are the calcium channel blockers. There are two main groups, the dihydropyridines or DHPs and the non-dihydropyridines or non-DHPs. The two most important examples of DHPs are amlodipine and nifedipine, while the non-DHPs are diltiazem and verapamil. If you remember those calcium channel blockers that are contraindicated with the use of beta blockers. Most importantly, the non-DHPs differ to the DHPs in that they have an additionally negatively ionotropic effect on the heart, as well as causing vasodilatation. This is important therapeutically, as amlodipine and nifedipine are used for their dilating abilities to treat hypertension and angina, while verapamil and diltiazem can also be used in the management of supraventricular tachyarrhythmias. The most common side effects of these medications are ankle swelling that is unfortunately unresponsive to diuretic treatment, headaches, and constipation. Important particularly for the exams, CCBs are one of the drugs, together with cyclosporin and phenytoin, that cause gum hypertrophy. The interaction between the non-DHPs and beta blockers has already been noted, but do not forget that these drugs also increase the effect of digoxin. Avoid their use additionally in heart failure. So lastly, let's talk about preventing cardiovascular events. The first step in preventing adverse events in patients with angina is education and lifestyle modification. This includes measures such as smoking cessation, increased exercise, and diet modification. In addition, 3 drugs or groups of drugs are prescribed as they have been shown in large multi-center trials to be of prognostic benefit in high-risk patients. These include a statin, that should importantly be taken at night, aspirin, usually at low dose, and lastly, an ACE inhibitor. Note, however, that the evidence for ACE inhibitors is fairly controversial. Not all physicians will advocate this. I'm going to cover these agents in much more detail in some other podcasts. So, in summary, the treatment of angina involves controlling symptoms and improving prognosis. The first-line treatment for symptomatic control is GTN spray, but also may include beta blockers, long-acting nitrates, and calcium channel blockers, either in isolation or in combination. To improve prognosis, patients are usually prescribed low-dose aspirin, a statin, and sometimes an ACE inhibitor. So, that completes this CPT podcast on angina and ACS. Thanks for listening, and see you soon.